Assalamu alaikum. I am Dr. K.M. Julfikar Hasan, lecturer at Department of Pathology, Boshundara Addin Medical College. Today I will discuss about the topics of gallbladder. This is the picture showing intrahepatic bile duct system. Here right hepatic duct and left hepatic duct to form the common hepatic duct, and finally this common hepatic duct unites with the cystic duct and to form common bile ducts, and these common bile ducts drains into the ampulla of Vater, which is situated in the second part of the duodenum. Now congenital anomalies of gallbladder. This can be congenitally absent gallbladder duplication with conjoint or independent cystic ducts. A folded fundus is the most common anomaly, creating a Phrygian cap. Agenesis of all or any portion of the hepatic or common bile ducts, choledical cyst. Now, what is cholelithiasis? That means gallstones. More than 95% of the biliary tract disease is attributable to gallstones. There are two general classes of gallstones. Number 1, cholesterol stones, and number 2, pigment stones. Cholesterol stones containing more than 50% of the crystalline cholesterol monohydrate. Pigment stones composed of predominantly of bilirubin calcium salts. Now, what are the risk factors of gallstones? It's the important topics. Cholesterol stones risk factors are demography, Northern Europeans, North and South Americans, Native Americans, Mexican Americans, advancing age. If increasing age, then there is chance of gallstone, cholesterol gallstone. Female sex hormones like as estrogen, progesterone, female gender, oral contraceptives, pregnancy, obesity and metabolic syndrome, rapid weight reduction, gallbladder stasis, inborn disorders of bile acid metabolism and hyperlipidemia syndrome. Pigment stones risk factors are Asians are more than Westerns, rural more than urbans, then chronic hemolytic anemias, biliary infection, gastrointestinal disorder like ileal disease, resection or bypass, cystic fibrosis with pancreatic insufficiency. These all are the risk factors of gallstones. Now, pathogenesis of cholesterol stones. Cholesterol is rendered soluble in bile by forming micelles with bile salts and lecithins, both of which acts as detergents. When cholesterol concentration exceeded the solubilizing capacity of bile, supersaturation nucleates into solid cholesterol monohydrates crystals. 4 conditions appears to contribute to formation of cholesterol gallstones. Number 1, supersaturation of bile with cholesterol, hypomotility of the gallbladder, accelerated cholesterol crystal nucleation, hypersecretion of mucus in the gallbladder, which traps the nucleated crystals, leading to accretion of more cholesterol and the appearance of macroscopic stones. Pathogenesis of pigment stones. Pigment gallstones are complex mixtures of insoluble calcium salts of unconjugated bilirubin and inorganic calcium salts. Disorders that are associated with elevated levels of unconjugated bilirubin, then chronic hemolytic anemia, severe ileal dysfunction or bypass and bacterial contamination of the biliary tree. Unconjugated bilirubin is normally a minor component of bile, but it increases when infection of the biliary tract leads to release of microbial beta glucuronidase, which hydrolyze bilirubin glucuronidase. Pathogenesis of pigment stones. Infection of the biliary tract with Escherichia coli, Ascaris lambda or the liver fluxi sinensis increase the likelihood of pigment stone formation. In hemolytic anemias, the secretion of conjugated bilirubin into the bile increases. About 1% of the bilirubin glucuronidase are deconjugated in the biliary tree, and in the setting of the chronically increased secretion of conjugated bilirubin, a sufficiently large amount of deconjugated bilirubin is generated to allow pigment stones to form. Now, morphology of the gallbladder. Cholesterol stone are exclusively in the gallbladder and range from 100% pure down to around 50% cholesterol. Pure cholesterol stones are pale yellow, round to ovate and have a finely granular, hard external surface, which on transaction reveals a glistening, radiating crystalline palisade. With increasing proportions of calcium carbonate, phosphates and bilirubin, the stones takes on a grey white to black color and may be lamellated. Stones composed largely of the cholesterol are radiolucent. Sufficient calcium carbonate is found in 10% to 20% of cholesterol stones to render them radio opaque. Pigment gallstones are brown to black. In general, black pigment stones are found in sterile gallbladder bile and brown stones are found in infected large bile ducts. Approximately 50 to 75% of black stones are radio opaque due to calcium salts, while brown stones which contain calcium salts are radiolucent. What are the complications of gallstone? It can be occurs cholecystitis, empyema gallbladder, perforation of the gallbladder, fistula, inflammation of the biliary tract, that is called cholangitis, obstructive cholestasis, pancreatitis, intestinal obstruction, increased risk of gallbladder carcinoma. Now, what is cholecystitis? Types of cholecystitis. Cholecystitis means inflammation of the gallbladder. Types are acute cholecystitis, that can be calculous cholecystitis and acalculous cholecystitis. Chronic cholecystitis, acute superimposed on chronic cholecystitis. Acute cholecystitis is precipitated in 90% of the cases by obstruction of the neck of the gallbladder or the cystic duct by a stone, and chronic cholecystitis without gallstones occurs in severely ill patients and account for the remaining 10% of cases. Acute acalculous cholecystitis is thought to result from ischemia. Risk factors of acute acalculous cholecystitis include sepsis with hypotension and multi-system organ failure, immunosuppression, major trauma and burns, diabetes mellitus and infection. Chronic cholecystitis. Chronic cholecystitis may be a sequelae to repeated bouts of mild to severe acute cholecystitis, but it many intense it develops in the apparent absence of antecedent attacks. Since it is associated with cholelithiasis in more than 90% of the cases, the at risk patient population is the same as that for gallstone. Now, morphology. The serosa is usually smooth and glistening, but may be dulled by subserosal fibrosis. On sectioning, the wall is variably thickened and has an opaque grey white appearance. On histologic examination, in the mildest cases, only scattered lymphocyte, plasma cells and macrophages are found in the mucosa and in the subserosal fibrous tissue. In more advanced cases, there is marked subepithelial and subserosal fibrosis, accompanied by mononuclear cell infiltration, then outpoaching of the mucosal epithelium through the wall may be quite prominent. This is the histological picture of chronic cholecystitis, picture showing the Rokitansky scope sinuses, mucous lining, mononuclear cell infiltration, subserosal fibrosis. There is extensive dystrophic calcification of the gallbladder wall. There is complete replacement of the gallbladder wall and mucosa by dense fibrosis, hyalinizing cholecystitis. This change is notable for being associated with an increased incidence of gallbladder carcinoma. Clinical features: recurrent attack of epigastric or right upper quadrant pain, nausea, vomiting and intolerance for fatty foods are frequent. Complications of cholecystitis: bacterial superinfection with cholangitis or sepsis, gallbladder perforation and local abscess formation, diffuse peritonitis, biliary enteric fistula, aggravation of pre-existing medical illness with cardiac, pulmonary, renal or liver decompensation. Now, carcinoma of the gallbladder. Carcinoma of gallbladder is the most common malignancy of the extrahepatic biliary tract. The most important risk factor for gallbladder cancer is gallstone. Gallbladder cancers are mainly adenocarcinomas and are most often detected in the fundus. They may be produce a firm poorly circumscribed mass or may diffusely infiltrate the wall of the gallbladder, stimulating the gross appearance of the chronic cholecystitis. Thank you everyone to listening carefully in patience.